Okay, good afternoon, everybody. I'm Emanuele D'Antonio. I'm a director of the Blood and Transplant Research Unit in Donor Health and Genomics, and welcome to this new seminar for our seminar series. It's a great pleasure today to have actually a trio of presenters. So Sarah, Simon, and Will that actually will present us some of the work they've been doing in terms of extended matching for red cell transfusion in sickle cell disease patient. And this is really a great opportunity to have Will, University of Cambridge, Simon, Oxford, and Sarah from UCL. So it's really sort of the golden triangle that we're hosting today. So, well, I'll without further discussion, I think it would be good to start. I think just a couple of housekeeping. I'm sure you all know now, stay on mute while presenting, and then at the end, we'll have opportunity to ask question. I guess we can use both the chat function, and otherwise I'll call you up and then you can sort of ask the question yourself. Well, up to you.
Thanks very much, Emanuele. And it's very nice to be able to welcome Simon and Sarah to Cambridge. And as Emanuele mentioned, we're going to be talking about this project, which has been called HemeMatch, which we're developing at the moment. And so we hope to tell you a little bit about what we've done so far and the problem that we're aiming to address and what we plan to do over the next few years. So this is an NHS-BT funded and supported study. So Sarah, Simon and I are all NHS-BT affiliated scientists, and the study has been supported and funded by the NHS-BT R&D committee. And the aim of HemeMatch really is to devise a method to provide precisely matched blood to patients undergoing transfusion. And by precisely matched, what we really mean is matching beyond the standard blood groups that you're probably familiar with, the ABO and the RH groups. And we have decided to start with a particular patient cohort which is heavily dependent on transfusion. That's sickle cell patients, and Sarah is a expert in sickle cell disease. She's a consultant hematologist who works specifically with sickle cell disease. So in the first part of the talk, she's going to give us an introduction to sickle cell and explain some of the clinical considerations. And after that, Simon is going to give us a brief introduction to some of the research gaps in the current treatment schemes. And then at the end, I will give a brief overview of what we hope to do. If you could move on to the next slide, please, Sarah, or Sarah, sorry. And so this slide just gives a brief overview of some of the people who are involved in this project. Some names you're probably familiar with. People from NHS-BT Diagnostics, IT, and clinicians. And I think I'll just hand over now to Sarah, and if you could just move on to the next slide, which I hope is Sarah's first slide. Thank you.
Thank you very much, Will, and thank you very much, Emanuele, for inviting us to speak today. So I thought I'd give this some context to our project by explaining a little bit about what sickle cell disease is and the problems that patients face, and then we'll round up with a clinical example of what happens when things go wrong. So sickle cell disease is an autosomal recessive disorder. The blood cells become very sticky, but it's not just the blood cells becoming sticky, and it's not just the red cells. You get a vasculopathy. You get a range of complications that I'll talk about shortly that may be acute, that is happen over a short period of time, and the background combinations that we call chronic. Next slide, please. So acute complications that patients can have can be divided up, can divide it up anyway. The way I find helpful is to think about them as vaso-occlusive crises. So that's when things get stuck in different vessels, and traditionally it's named after the bit of the body where the problem's actually occurring. So if it's in your brain, it's a stroke. If it's in your penis, it's a priapism. it's in your abdomen, it's a girdle syndrome, but it can happen pretty much anywhere. And a characteristic one is a simple painful crisis, which occurs in the muscle and bone and can be excruciating. But other crises that may occur along with your vaso-occlusive crisis can be due to parvovirus B19, sequestration when things pool in your liver and spleen. It's a hemolytic disorder anyhow, so red cell destruction is increased when you're unwell, above a baseline of what you're already destroying your red cells at, but it can be associated with a blood transfusion reaction, and patients are prone to infection both due to hyposplenism but also bone ischemia. Next slide, please. Long term, patients may suffer from problems that are, you could just press another button, all of them, thank you, to do with vasculopathy. And if you know anything about things like diabetes and other vasculopathies, these are pretty similar. So you'll get any organ where you can get small or large vessel damage will start failing. And by the time you're as old as me, if you have sickle, you've usually got a selection of these, if not all of them. Next slide, please. There's not much in the way of treatment, preventative treatment for sickle cell. Hydroxyurea is often used. It's not suitable for everyone. You need fairly robust blood counts. You can't take it when you're pregnant or trying for a family. If we go to the next slide, you'll see actually a whole range of studies which are basically to do with stroke prevention, which shows such significant reduction in stroke prevention from regular transfusion that you can't really offer hydroxycarbamide in that setting. So the other additional issue that blood transfusion uses for treatment during a crisis, other than supportive care, which we mean fluids and antibiotics and whatever needs doing, there isn't anything else that really turns around an acute event in sickle cell, and blood really is the therapy that we have to do that. So we're very dependent on blood transfusion to keep our patients well, both in a long-term way, but also when they get acutely unwell. Next slide, please. So you have two reasons really to transfuse a patient with sickle cell. And that's either you want to increase in hemoglobin, or you want to decrease the percentage of sickle cells to get the flow going to reduce the crisis. It's sometimes both of those combinations to be true. Sometimes you want to do both of those things at once, but not always. And the reason you will be doing it is either to treat a complication, or more frequently to prevent one from occurring, usually a stroke. Next, please. So just to give you some context of how many patients we have and what the scale of the issue is, there are about 14,000 patients with sickle cell in the UK, and about 80% of them reside in the Greater London area, with other pockets where you'd imagine in the Northwest, the Midland and the West Midlands. And thalassemia, which is an associated disorder, is a much smaller cohort, which we will be looking at in some detail also. But for many patients, their medical lives are defined by access and the need for red cell transfusion. They're very dependent on it, either as an emergency or as part of a long-term transfusion programme. Next slide, please. So we wanted to understand, everyone was asking me when I started this job, what is the scale of the problem? What is going on? So we did two things. One we did is a national comparative audit of blood transfusion sickle cell disease, which you can read about. And national comparative audits are a programme of audits, usually a couple of a year, that are done by the blood service to look at usually where blood is going in different clinical settings. So we did one with sickle, and we got 84 hospitals and over 1,200 cases. And interestingly, most of the cases came from a few number of hospitals. Most of the patients had homozygous sickle cell disease. The vast majority had RO phenotype. For those who know blood grouping, that is a blood group that is present in under 3% of donors of European ancestry, which is most our donors, and in 60% of people of African ancestry. So a discrepancy between the blood donor pool and the blood recipient pool is quite striking from this data. What we also noted was the vast amount of people being transfused for stroke prevention, particularly in children, and a large amount of children being transfused. And then for in an acute setting, it was usually anemia or chest syndrome, which is the commonest cause of in-hospital acute death. Next slide. The hemoglobinopathy survey was slightly different. That was looking at how patients were receiving blood and the antibodies and the antigens. And once again, there was some overlap with the other study, which it shows exactly the same proportion of patients receiving the RO blood. It looked at antibody formation. About 17% of patients had antibodies. Remember, this is patients who are receiving transfusions, and we can talk a bit about that later. But there was a real discrepancy between what guidelines were saying and what people were doing, and what care was available to these patients, particularly in the case of the transfusion care. There was a real postcode lottery. Next slide, please. So just going back to your basic science, you're all scientists, I don't know why I'm doing that, but these are your blood groups, or some of your blood groups. There's many more than we have, and for sickle cell disease, we routinely match against the ABO group, which you can see there, the full RH group, and KEL. So we would give blood compatible for that. That's in contrast to our average Joe Bloggs, who will get just blood compatible for ABO and the letter D, which you can see within the RH group there. So we already match a bit more than normal. Having said that, that's clearly not enough for this cohort. Next slide, please. So how do we work out what blood groups our patients have and our donors have? Well, traditionally we do a phenotype because that's what was available. But since 2016, we've been able to do genotypes on our patients. But at £500 a pop, it's proved to be a bit expensive for most trusts. And when we looked at our data, a lot of patients haven't had it. The advantage also of genotyping is that you can look for variants, which is particularly an issue in patients of African ancestry, and also you can do it if they've recently had blood. So if you've got your thalassemia cohort, for example, they never don't have too many negatives there, but they've always got someone else's blood on board, so you'd never be able to do a phenotype on them. But as some of the work you'll hear about shortly is going to be a real game changer in what we can deliver in terms of genotyping both our patients and our donors. Next, please. So why do we care if patients form antibodies? Well, the reason we care is they can become really, really unwell. They may destroy the blood you've just given them. And then, of course, they haven't been cured of their underlying disorder. So you've then left with a patient who still needs blood. And so then you've got less blood that's available, maybe suitable for them. And it might get to the stage, if they form certain antibodies or certain combinations of antibodies, that we really have very little donors in which to choose to give them blood. And remember from the hemoglobinopathy survey, a person who is on an exchange transfusion, on average is used 67 units a year. So it's a lot of blood. So you need to find at least a lot of donors who would match that very now constrained antigen genotype from your population, and it just might be impossible to deliver their care. And in some settings, especially if an urgent transfusion is needed, you might just not be able to get blood for them. So this results in major morbidity and death in a cohort of our patients. Next slide, please. So I thought I'd give you an example, and if any of you have been to BBTS, you might have heard me give this. This is a case that made me frankly sleepless. But this is an example of what can happen when things go wrong, even if you've been really, really, really careful. So this was a 46-year-old woman who had sickle cell disease, had a relatively mild disease. So she's 46 and she'd not really spent much time in hospital for her sickle cell disease, had a bit of trouble during pregnancies, but otherwise quite well. She gets breast cancer and she gets seen at a cancer place with no sickle support, and she doesn't really tolerate the treatment, and they sort of give up slightly and decide that she needs to be seen, which she probably needed to be seen for in the first place, in a place that could deal with both cancer and sickle cell. So she came to us. Next slide. And actually, if you take a proper history, it's a bit, I got just told by the cancer people she just has a bit of sickle, but of course she's got some antibodies, and she's developed some quite significant antibodies, anti-JKB and anti-KEL. And when I saw her, we also picked up anti-big C little e and anti-little s. And then I thought I'd do genotyping because it was available, and that was a mistake, because look what I found. She had variants coming out her ears, and there was a lot going on there. But I felt fairly confident because she'd had a recent transfusion, apparently with no delayed hemolytic transfusion reaction. Not that anyone had looked that hard, and she'd only been given 1 unit, so you might miss it. But I was feeling fairly positive. I knew what she had. I knew what we could give her. But I thought, next slide, please. I thought what I'll do is just play it safe and not give her blood and try and manage without blood. And actually she did very, very well. And I was feeling victorious and like a good doctor. But then I get back that she's got the BRCA mutation, and now what they want to do is a great big operation. And quite frankly, she's a 46-year-old woman who needs major surgery, and she's not really going to tolerate that without transfusion. So next slide. So I was a good girl. I did what I was supposed to do. I consulted with the red cell immunohematology team. I suppressed her immune system so to decrease the transfer reaction, and we give her a transfusion, and I'm feeling really good about things. Next slide. And then of course it all goes horribly wrong, and quite typically what happens then is you get a bit of a lull, and then the hemoglobin starts appearing in the urine. So you've got breakdown in the blood of the red cells, and it appears in the urine. I look at the urine, it's all hemoglobin A, so it's all the blood she's been transfused, not her own blood. And you might say, well, that's fine, we'll just give her some blood and we'll top her up. But the problem was I'd exchanged her, which meant that only 12, sorry, that should read HBS post-exchange was, that's what said HBA, but it should be HBS, was 12%. So only 12% of the blood in her system was her own, and she was now going to destroy the rest of it, which would give her a hemoglobin that would be incompatible with life. And I knew that was just around the corner. So she'd been given O little r actually, and in retrospect, I don't think that was a terribly good idea. Next slide, please. And this is what happens. And if you look, the hemoglobin is in blue, and the bilirubin, which is a breakdown product of hemoglobin, is in yellow. So that goes up when the hemoglobin goes down. And the S percentage is how much of her own blood is around. So that goes up steadily. And what we did was, with the arrows, which are transfusions, we had to give her some transfusions, but she hemolyzed all of those as well. It made no difference when we gave her blood. She just hemolyzed everything we gave her. And we stimulated her bone marrow to make her own red cells, and she survived, and thanked me for my excellent care, which didn't feel very excellent at the time. But it was a very, very difficult few days, and we were very much reliant on her bone marrow making her own cells, because everything we were giving were being destroyed. Next slide, please. So actually, when we got to the end, and this is a picture of her urine bag, which I've got consent for, if you can see, the urine in the tube is the stuff that's coming out of her, and in the little front pocket, the hourly urine thing. But in the main sac, you can see what's called hemoglobinuria. So that's what hemoglobinuria, we describe it as Coca-Cola coloured, which is actually what it looks like. But once it starts running yellow, it means that the hemoglobin, the red cells are no longer hemolyzing. So that cheered me up immensely. Next slide, please. So that's a real case of a life-threatening episode where we were lucky to have her at the end of it. She hemolyzed everything we gave her, whatever we tried to match to, she hemolyzed. And she now has no real alternatives for a subsequent transfusion episode. She's only 46. She wants a hip replacement because she can barely walk. And I don't think we can give her blood anymore. So that's what happens when people have lots of antibodies. You can render them untransfusable. Thank you, and over to Professor Stanworth.
Sarah, thank you for that. Thanks, Emanuele, for the invitation to come over to Cambridge. Hopefully we'll be able to do that in real rather than virtually at some stage. What I want to do in this next 10 slides or so is just think a little bit more about what we want to do next, how we want to move the research agenda forward. And I think, as most of you know, this is very much a research program in its infancy. So we're hoping to start off in April. So this is very much not giving you data, not giving you results, but this is some of the ideas that we have framed moving forward. Next slide. What we often do, and I've used this over my career, is just think about, the different steps along that pathway to research. And ultimately, what we want to be looking at are the kind of clinical studies, as you can see at the bottom, number 5, the clinical studies that might really inform and change practice here. But there are obviously those earlier steps along the way. And Sarah's really nicely described what we've been hearing from our patient panel, our PPI, our patient panel engagement. We hear all the problems that Sarah's been describing. These are topics, these are areas that the patients want us to do more for. But we might have the ideas, we might have the research questions, but often you've got to also think about, well, what else is going on? Has some of this been done before? and what can we learn about epidemiology? What can we learn about current practice? So in some ways, what we're doing with the HeMatch program is thinking about some of those steps, or more kind of 3, 4, and 5. Next slide. We're quite fortunate in a way. This is not just a research gap that's been identified here in the UK. It's also a research gap that's been identified in other publications, and to some extent these really importantly inform what's happening elsewhere. So there have been a couple of guidelines, evidence-based guidelines, that have been published in the last few years, and in particular the one on the next slide. So the first one I'm going to start off to say something about is this. This was American Society of Hematology guidelines for sickle cell disease. It was addressing transfusion support. So there was felt to be enough uncertainty and importance that a specific guideline needed to look at this question of how we do transfusion support. Really, there's quite a wide-ranging group of individuals around the world. Some of you may recognise, for example, Joe Howard here, who got involved in this guideline. Now, I'm not going to show all the aspects of this, but I just want to pick out a couple of themes that came through from this guideline. Next slide. So one of them is very much what we've been hearing from Sarah. Transfusions are key for these patients. We need guidance, but they have problems. And this was about developing an evidence-based guideline for the use of transfusions. Next slide. This slide summarises some of those questions that came up in this guideline panel. And one of the reasons why I'm showing you this is, actually there are a lot of questions here that are directly relevant to patient care. We picked up earlier in this talk about the importance of antigen matching and some of the problems that happen if you've got inconsistencies, incompatibility. But there are also a whole range of other transfusion questions. I remember very much when I was a junior doctor, there were questions around automated exchanges, manual exchanges. You can see these coming through. How do we use prophylactic transfusions in some of these patients? And right at the bottom, and this is also a theme for other groups of transfusion-dependent patients, is that management of iron overload, which can be an inevitable consequence of too many transfusions. Next slide. And in fact, with time, I'll just go on to the next slide, please, Sarah. This slide just summarises one of those questions, and I'm really showing this because I want to illustrate the problems this panel had in making recommendations. So this was one of them around that role for different degrees of antigen matching in these patients. But what I think you should be able to see towards the end of that top paragraph is that whatever they were able to make, whatever statement they were able to make, was based on very low certainty. The levels of supporting evidence for these recommendations were not based, did not have a strong, firm basis. And actually, in the discussion around this recommendation, this expert panel highlighted a number of those issues that Sarah was also describing earlier. And particularly, you might be able to see, looking down, some of the challenges of serological investigation and how there might be advantages for genotyping moving forward. Next slide. So really, they were some very important recommendations that came out of this guideline, but you can't help but notice that, strikingly within the discussion part of this document was that the authors recognised that there was low or very low certainty of the evidence that could support many of these statements. And they talk about, again, the potential burden of transfusions, emotional distress, time required to undergo transfusion, loss of income, lots of issues around how we use transfusions. Next slide. Now, I've showed an international and American Society of Hematology guideline, but other guidelines have been coming out. This was one that came out from the International Collaboration for Transfusion Medicine. I'm not going to go through it, but inevitably, and what's quite appropriate here, is that each country can draw on those guidelines and try to think about them more as to how they apply within your own country setting. And so, as part of the transfusion task force of the British Society of Haematology, there was a specific exercise reviewing this guideline for use in the UK. Next slide. This is the only slide I really want to show from this, because I think it comes up against that again with that problem of lack of convincing evidence. If you just read that last sentence here, so this is reviewing the International Society guidelines, and our authors for the British Society of Haematology welcomed a lot of consensus here. These were sensible statements, but there were also concerns, and actually used the word disparity here, around some of the recommendations here for extended matching. And my interpretation of much of this is that, again, the underlying problem here is that we just haven't got that certainty, that evidence base to be able to make these decisions appropriately and in the best way for our patients. Next slide. So really that was a little bit of the further background, if you think back to that research cycle, about what we wanted to do on this HeMatch programme. And we've spent a lot of time over the last few years thinking about these, what we call work packages or interrelated projects. And what we want to do here is to establish in a more iterative, evidence-based way the process by which we can look at the matching of patients to donated red cell units for transfusion. Ultimately, we want to improve outcomes for our patients with sickle cell disease. In a sense, our hypothesis is that by extending that matching, we can help aspects of the routine care, more cost-effective processes, which can improve outcomes. And you'll see in the bottom right-hand side some of the potential benefits here. And although we've been talking much about risks of alloimmunization per se, don't forget there could be a whole host of other benefits here. For example, it's well known that there can be delays in transfusion, which can be important for these patients. And cost efficiencies, cost effectiveness will be a very important highlight. Next slide. So this is more of a diagram just summarizing some of our proposed work that we want to do. And we've got these individual work packages, but central to it on the top left-hand side is thinking about patient-public involvement. And this is hugely important here. I mean, we've mentioned, groups of sickle cell patients. These patients often come from different ethnic groups from Africa. We've also got to think about genetics, genetic testing, and the implications here. We need to deliver this research in combination, very much linked up with our PPI panel. And then very briefly, the next couple of slides, and then I'm going to hand over to Will, just thinking a little bit more about what we want to do on these work packages. And this is the first work package that we want to do. And almost we want to create a better database of these patients with sickle cell disease. We have a unique because of the very joined up nature of the hemoglobinopathy centres in this country to work together. We want to understand what happens to these patients. We want to understand their outcomes. We want to think about what happens to their transfusion history and their current standards of matching. And this, in a sense, will frame many of the later work packages, including some of the research that Will's going to be describing to us in the next few slides. So again, it almost goes back to the research cycle, those first steps. Next slide. I didn't think it didn't take us very long to start to recognise, and I'm sure this will be a feature in many other areas of research moving forward for NHSBT, that actually how we transfuse these dependents is very and critically dependent on information flow, data flows. And we need to think about ways that improve and enhance the connectivity between some of these key IT systems in NHSBT, but also particularly, externally facing how some of this can work between NHSBT and our hospital NHS colleagues and partners, and in particular the National Hemoglobinopathy Registry. So work package 2 is going to very much think about some of these aspects. And I have to say, I think for many of us who have, touched base with some of these IT issues, this is something that brings me out in a bit of a cold sweat sometimes. How can we improve these the IT connectivity, because that's going to be fundamental to the work that we want to do moving forward. Last slide for me before I hand over to Will for the final bit of this talk is really, we want to think about some of those different typing platforms, those antigen typing platforms for donors and patients, how we're going to incorporate those. There's a whole host of other research ongoing in NHSBT at the moment that is looking at these. And we've got to bring this all together in terms of a clinical study protocol that can test better ways of looking at antigen matching for these patients, think about different ways of delivering it, but also very much based around the IT systems that we will increasingly see in our hospitals and in NHSBT. So that slide, thank you very much, and I'll now hand over to Will.
Thanks very much, Simon. So in the last few slides, I'm just going to describe in a little bit more detail some of the problems that we need to address as part of designing a precision blood matching scheme. And really this has become possible because of the Blood Transfusion Genomics Consortium, which has been set up as an offshoot of the BTRU in Cambridge by Willem Ouwehand and Nick Liddell. And this is a consortium of, I think, 10 or 11 blood services worldwide. So it includes the South African Blood Service, Sanquin, the Dutch Blood Service, Australia, Finland, and a variety of blood services in North America. And they've all come together to design a genotyping array which can be used to measure transfusion and transplantation specific genetic variations in a much cheaper way than is possible at present. So Sarah mentioned that the blood service currently has a transfusion genetic test which costs about £500 and will measure all the genotypes relevant to transfusion. But that's not something that can be applied in practice, for example, to millions of donors, which is what you'd need to do if you wanted to search for rare blood groups or rare blood types in the donor population to identify donors that might be suitable for transfusing blood into a heavily immune sensitized patient like the one Sarah was describing earlier. So the aim of this consortium is to develop a universal blood typing array, and they've pretty much achieved that. So if we could move on to the next slide, please. And that has been done by Nick Liddell, as I say, who is based in Cambridge and has been working with the BTRU. And he's updated the UK Biobank array and carefully included probes on the array which are capable of measuring key genetic variations in blood group genes, and also in platelet blood type and neutrophil blood type genes, but specifically in red cell genes, which are the ones that are relevant to our question here. And they've also developed a slimmed down version of this array, which can doesn't measure genome-wide variants, but just measures variants specifically in the blood group genes, and that can be applied at a much lower cost. So I think that costs about £11. We'll move on to the next slide, please. It's about £11 per test. And you can see on the right-hand side here, a figure taken from Nick's paper. And so on the left-hand side here, we have data from NHSBT. And on the right-hand side, we have data from Sanquin, which is the Dutch Blood Service. And both the left and the right are essentially the same, just data from two different cohorts. The top panels show the results of serology tests. That's the phenotyping test that Sarah described earlier, which are done by blood services to identify the different blood types for various blood groups on donors. So each row of this plot corresponds to a different donor, and the coloured rows correspond to the presence of information about a particular blood type in the blood service database. So you can see each column corresponds to a different blood group. You can see that both NHSBT and Sanquin have almost complete information in the two left-hand columns. Those are the columns that correspond to the ABO blood group and the D blood group. But you can see that otherwise there's quite a lot of white space. So there's lots of spots in the database that don't have the blood type information in. So a lot of uncertainty about the blood types of donors. You can see at the bottom where Nick's genotyping array has been applied, that all the gaps have been filled in. So pretty much complete coverage, just a handful of missing data points. So this is what really allows us to develop a universal blood matching scheme. And if we could, okay, so I should just perhaps before we move on to the next slide, mention that this array is going to be applied over the next 3 years to about 1 million NHS-BT blood donors, and also to about 5 million participants in the Our Future Health study, which is a large epidemiological study. It's going to recruit people through the blood service and through other routes. And that will, of course, give us a large panel of typed individuals from which we can search for suitable donors with rare blood types. We can move to the next slide, please. Thanks. So what do we need to think about when we are developing a matching algorithm? There are a number of biological constraints on the type of blood that you can transfuse into a recipient. So the major constraint that Sarah has discussed already is that you cannot transfuse blood into a patient if the blood contains an antigen against which the patient has already developed an antibody, because if you do that, there's a risk of organ failure or death. And then secondly, slightly less severely, it's best not to transfuse blood into a patient if the blood contains an antigen which the patient doesn't physiologically express, so don't have themselves, because if you do that, then you risk generating an antibody against the antigen that you've transfused into the patient. And that means that next time you can't transfuse that antigen again if the patient needs another blood transfusion, because then there's a risk that the patient might have a response which risks death or organ failure. So antibodies can arise from previous transfusions, but they can also arise from pregnancy. So I think about 80% of antibodies identified during cross matches in hospitals are in women, and that excess is explained by antibodies generated in pregnancy against fetal antigens. So these are all constraints we need to think about when we're designing a blood matching algorithm. And of course, at the moment, if a patient needs blood urgently, then a consultant may choose to put aside some of these constraints, because it's more important that the patient is given blood than that the risk of a transfusion reaction occurring. So we need to build all these considerations into a blood matching algorithm. Could we move on to the next slide, please? Thanks. So what are the aims of a matching algorithm? So at the level of the individual patient, we need to make sure that compatible blood is available for every transfusion. At the same time, we want to reduce the probability that a patient becomes untransfusible in the future because they've been transfused with so many different antigens in the past that they have antibodies against all the units in the blood stock, or all the potential units that could be identified from donors in the donor pool. We also want to minimize unnecessary alloimmunization. The problem with just considering these utility measures at the level of the individual is that there is potential competition between patients for the same units of blood. So it may be that a patient who has elective surgery in a week has a particular rare blood type that matches that of a sickle cell patient, and there's only one unit of blood in stock. So then you're in a situation where you have to decide which of the two patients are going to get the unit of blood. So we need to consider the utility at the level of the population. We need to try and identify a matching scheme which maximizes utility across the whole population, not just at the level of each individual patient. We also need to think about minimizing wasted donations, so outdated stock. We need to minimize the burden on valuable donors, so we don't want to ask the same donors to come back repeatedly and frequently in case we put too much stress on them. We need to also ensure consistency across hospitals, so to ensure that patients get good care, whether they're in a large urban area where there are lots of ethnic minority donors, or whether they're in somewhere in the countryside. And we also need to improve the automation and the efficiency of the system. Next slide, please. So what do we need to think about initially to try and start developing a matching algorithm? So the first thing we need is a model for the immunogenicity of each antigen. So we need to understand if a mismatched unit of blood is transfused into a patient, what's the probability that that patient will develop antibodies against the mismatched antigen in the blood? And we think that's likely to depend on various covariates, so on sex, background antibodies that the patient already has, the blood groups of the patient, the type of disease state of the patient, and the transfusion history of the patient. So we need to try and understand how all these factors potentially affect the immunogenicity of antigens. And we hope to do that with data collected from various hospitals on patients with various types of transfusion-dependent disease, so sickle disease, thalassemia, which we are in the process of collecting at the moment. And this will allow us to estimate or get some idea of the cost of mismatched transfusion costs. We also need to model the distribution of blood types in the NHS stock. So we need to develop a model for the probability that a particular donor, a particular blood type is going to walk in the door in the next week or the next few days. And we also need a model for the distribution of blood types in the donor population, because it may be the case that if we don't have blood in stock, we have to use a call center to call a donor up. And as well as that, we need to understand the distribution of antigens and antibodies in the various patient cohorts. So initially, as we've mentioned, we're going to be focusing on sickle cell disease, where patients are heavily transfusion dependent, and as a result, they tend to have developed a large number of antibodies, particularly because they often come from less developed countries, where they may have had less careful treatment in the past. So it's possible that they've developed more antibodies than they would have done if they'd been treated in the NHS. And both 2 and 3 would allow us to estimate the cost of issuing units to patients and the opportunity costs of issuing them to one patient if another patient may also need the same unit in the future. We can move on to the next slide, please. So we're lucky to be collaborating with Sanquin, which is the Dutch blood service, and they've thought about these problems quite a bit already. And Guus van Sambek, who's a PhD student at Sanquin, has been developing algorithms to match blood and to model blood stocks in the Dutch service. So we hope very much to be able to rely on some of his work and modify that and develop it for implementation in NHS-BT. We could move on to the next slide, please. And just the final slide to mention some future possibilities. So we're initially going to be focusing on sickle cell disease, but later we hope to move on to other heavily transfusion dependent populations, patient populations, so patients with thalassemia, bone marrow failure, bone marrow fibrosis. In the future, it may be possible to try and integrate elective transfusion schedule data. So if we can get the IT systems integrated, it should be possible for us to get information from hospitals about the upcoming surgery that they plan and the possible transfusions that they may be able to perform in advance, so that we can make sure that NHS-BT has the right blood in the right place at the right time. And finally, it should be possible in principle to integrate donor invitation systems with a blood matching scheme. So if we know that a patient with a particular rare blood type is going to need transfusion in a week's time, and we don't have any blood in stock, in principle, we should be able to target donor invitations at the donors with the red blood types in the donor pool and ask them to come in to donate. And I think that's my last slide, but if we could just move on to the next slide. Thanks very much for listening, and I think we're happy to take any questions you might have now.
That's super. Thanks, Sarah, Simon, and Will. I think great talk and great overview about this really fascinating project. Any question from the floor? I think you can either use the chat or just raise your hand and ask the question. I'll maybe start. So it's one of the challenging, as you mentioned, is really about the IT infrastructure for NHSBT and actually the different hospital. Any more detail about how you plan to tackle that, especially given the potential decentralized nature of the different hospitals that will treat patients?
That's a really good question, actually, and it's something that creates a lot of thought and discussion amongst our group. We've got on our group some IT experts, and we're basically dealing with it in two different parts. One is NHSBT and one is the hospital. And at the hospital side, we're starting off with UCLH, partly because I've worked there, which makes it easier, but also Willem has been doing some work there already with the Haematology Data Science Initiative. So that there's quite considerable overlap between those two projects in respect for the hospital side. So we are doing you have to initially do a mapping process, and then you have to look at how you will pull the information from one system to another. I know the Blood Genomics Consortium with Nick Gladell and Willem and co have already done quite a bit of work looking at how they're going to extract the data from the Gene Titan platform into the database. But I mean, an example of one of the challenges, which I'm sure you're well aware, is that currently donor typing is in one system and patient typing is in another. So that's already, and that blood is ordered from hospitals, for example, without any details about which patient it's going to and what their genotype might be. So there are a lot of bridges that need to be crossed to make that work. That will need a lot of investment and support. But we are making it a real priority to make that work.
Thanks. I'll ask another question as well in the meantime. So at the moment, this project is really focused about sickle cell disease. And how do you see the scope for in the future to expand that to the broader domain about the donor recipient matching, not only for this particular patient that actually they're very relevant and possibly the most relevant, but how much, and if you see that evolving in a wider angle view.
Simon, do you want to answer that, or do you want me to?
Yeah, should I take that one then, Emanuele? I mean, we're certainly aware of a lot of potential implications here. So if you, for example, think about some other groups of patients who are heavily transfused, transfusion dependent. I mean, I'm thinking here of some of the malignancies, some of the bone marrow failure conditions where there's transfusion dependency for a period of 2, 3, 4 years sometimes. And many of the issues, perhaps not to the same degree, but they arise in those groups of patients. So certainly in myelodysplastic and the chronic cancers, we see alloimmunization, and it can raise a whole host of challenges there. It is something that we're looking at from the other side. So we're talking here about almost providing the blood, but for your typical MDS patient, what they really want to understand about is functional quality of life. And so if we're able to use these better ways of matching blood, we might actually be able to give the blood to these patients in a very different way. I'm going to choose my words quite carefully here, but it might be that, for example, we can look again at some of the critical steps of compatibility compatibility testing that are a key component of what happens in the blood bank laboratories in the NHS. So, I think that's looking into the future a bit. But if we're in a position where we're providing, optimally matched red cells, do we need to do the same degree of testing and compatibility testing and checking each time? Here's another idea. Does it open up avenues for transfusing at home? I mean, for sickle cell patients, but also for a lot of these other patients, lots of steps in that pathway to coming up to having a unit of blood tested, checking their antibody status and so on. So we could end up refashioning many steps of the transfusion pathway. But I think we've identified sickle cell, but I think, MDS, some of these chronic bone marrow failure disorders, I think particularly some of the hematologic malignancies. I haven't said anything about thalassemia, but that's another group that's somewhere, here as well. So I think there are a number of avenues there.
Excellent. Thanks a lot. Any other question from the floor? Rachel.
Hi, I hope you can hear me. I've had microphone problems today. Good, excellent. This is really fascinating work and clearly really worthwhile. I'm thinking there are some synergies with work in organ transplantation as well, and that those are a group of patients who are, often transfused, but also does what you're doing have some relevance in terms of organ matching also? Not just sort of blood, but would it be relevant to the way in which organs are matched between donor and recipient?
So it's a really interesting question, and of course I have zero expertise on organ transplant, but I would say that the way we are doing this is to be as a paradigm for other scenarios. So we're starting off with sickle as a sort of proof of concept, because they are a defined cohort, they need blood, and they're not thousands and thousands, well, they are thousands of people, but not hundreds of thousands of people like MDS. So it seems like a manageable cohort to start with. But if you can bring together IT systems across the organisation, if you can have IT systems mixed, interact between hospital and HSBT, then that can be used for paradigm for other aspects of matching too, I would have thought, although it would need to be adapted. I mean, to be fair, it would need to be adapted for other patient groups, even if we're talking about blood, because the matching paradigm for a patient with sickle cell disease and a certain set of genotypes may be quite different than how you would do it for a patient with thalassemia, whose genotype much more closely matches or mirrors the current donor genotypes of most our donors. So I think it's a point of principle. It's talking about connectivity, interaction, paradigm building, how we build a database and inform our matching strategies to make them evidence-based, particularly for the patient cohort. And I think those principles could be adapted to other settings, which may include organ transplant, not that I know anything about it.
Thanks, Sarah. I think it's really interesting, that concept that Will mentioned about that it's at population level that you need to sort of maximise the benefit, and that brings some sort of novel challenges. It's really fascinating.
But it's both, isn't it, really? Because of course, when I see a patient and I can't treat them and they're young, well, even if they're old, it's not exactly nice. And it's because of something we've done to them or failed to do for them. It feels like a failure of what we've been offering when you render a patient untransfusible. I mean, a lot of it's historical, so there's not much I can do about it now. But looking forward, we shouldn't be putting patients in this position and clinicians in this position where we have a patient cohort that we can't treat, because it seems to be avoidable if we get this right.
Excellent. Thanks a lot. Any other question? Well, if not, well, thanks again. It's been a great talk, great discussion, and well, thanks again. And there's in this virtual world, you have a virtual chat with a clapping on to all of you. And Sarah, when is the next seminar? Will be in.
The next seminar is in March, and That's going to be on blood group genotyping, so following on quite nicely from this talk. So that will be Nick and Willem and Connie Westhoff from the New York Blood Center. So that is on the 11th of March. And there'll be a little bit about the blood group genotyping at our Cambridge Festival talk as well, which is on the 30th of March.
Excellent. Thanks a lot. Well, thanks for attending, and hope you have a nice afternoon and a nice weekend.
Thank you.
Thank you very much.
Thank you.